Good afternoon, everybody. Thank you for asking me to speak. Emergency general surgery, how can we make it better? We've heard some of the challenges. It's a common, mortal and costly problem. 30,000 emergency laparotomies a year, the largest part of our general surgical practice, and we've heard that there's a twofold at least variation in outcome when you compare one hospital with the next. In an outcome-driven NHS, given that this accounts for 90% of all our surgical deaths, you can see that this is going to be the single largest factor that influences where the hospital or where the unit sits in the inevitable league tables. It's come to the public eye in the last year, it's costly, it's not going to go away. So what can we do to make it better? Well, here are some of the things we're going to think about over the next 10 or 15 minutes, and to some degree, I know, in the talk that follows mine. We can adopt standards of practice, we can improve our access to key resources that we all know are woeful at times. We can consider different ways of how we deliver emergency general surgery. There are significant manpower issues that we've got an opportunity to fix at the moment, and we need to think, as Adam has said, how we train future consultants to fit the need. And ownership of EGS we'll touch on at the end. There are a series of supporting documents that have come out over the last year, and these lay out a number of things, but first and foremost, the role that I would see for them is that they're there to help individual consultants set out to make their own emergency services better. Having laid down guidelines and standards was one of the things that came out of the survey we did 2 or 3 years ago that consultant colleagues felt would help them be able to improve their service. You can go to the managers and say, this is what the specialist bodies say, this is what we need. The first document you see there is a college document applicable to all of emergency surgery, orthopedics, neuro, general. The second one, the higher risk general surgical patient, joint with the Department of Health, focuses in on perhaps 10 things that every general surgery unit would be able to do to make their service better. General recommendations in those two you see there, clinical priority based on illness severity. And as we've heard, that isn't always the case. And what the documents do is to set out to try and define seniority, the exam qualifications that individual staff should have, relate to existing clinical guidelines from NICE, and how you should respond in different ways to different clinical circumstances. The final document is in your packs, the Issues in Professional Practice from ASGBI, which sets out to try and encapsulate some of the issues such that you have that information to hand when you go to your manager and say, these are some of the things we need. So I hope you'll find them helpful. What about specifics, though? Well, first and foremost, I think is that each unit needs a robust system for responding to unwell patients promptly, because time makes a real difference. That applies to both new emergencies and elective patients going off on the ward. And in many ways, the survival clock, if you like, starts with illness onset and not with the phone call to the boss. Often the EWS will let you know or let the nurses know through the NICE CG50 thing that I'm sure your hospital runs, though you may not be aware of it, that there is something wrong. But what we need to do is to get an adequately senior response to the critically ill patient, and I think nowadays that has to be someone with the MRCS. You need not only the knowledge, but also the organizational skills to make things happen rapidly enough to get the whole process for a potentially complex and unwell patient off on the right foot. The early speed of resuscitation and investigation sets the tone for the whole process. This slide I've shown you before shows the impact of time of antimicrobial therapy in someone with septic shock. And you see that for relatively small aliquots of time change, you get a measurable difference in outcome. Most of our patients, of course, don't have septic shock, they've organ dysfunction, but they're on the same slippery slope. We would advocate that you follow the surviving sepsis guidance and that these patients get antibiotics within an hour. You know that antibiotics and resus is only one half of the sorting out sepsis angle. Source control is the other one, and here you see the impact of the cross-tabulation of different times of source control versus different times of antibiotics. And I would suggest that for many of our patients, the orange box would be about where we sit. We could probably do better with that. But fundamental to that, is time to operation. And this is one of the things laid out to try and help in the higher risk document. The first category is self-explanatory, but the septic shock patient outcome varies significantly with relatively short delays. 80 or 85% of our patients, however, would sit in category 3 here, severe sepsis with some means of organ dysfunction, oliguria, hypoxia, etc., etc. And we would advocate that those patients have a maximum of 6 hours to avoid deteriorating into septic shock. And that's not what happens at the moment, and certainly wasn't what used to happen in our hospital, as I'll show you in a moment. How are we going to achieve that, you might say? Well, these cases have to take more priority over elective cases. Seniors have to be there to drive the process and to make sure the operation is reasonably speedy. It needs not only physical theatre access, but you need to have an ODP at 5 o'clock in order to use the theatre that's there. The guidelines are there to help, but it's a sad fact that no one can do this for you. And certainly in our hospital, and I know from a number of colleagues who've been in touch, that in a series of hospitals, there's been a theatre access remodelling process. And if you have problems with theatre access, as we know at least half the units have, this certainly seems to be worthwhile. What it involves is sitting down with all interested parties, theatre, organisers, theatre managers, consultant colleagues, anaesthesia, and just working out where there are little gaps in the theatre schedule, the lists that always finish early, when people are on holiday, how can you move the system around? And we've done that, and we've also taken a 1 in 12 loss of a half day of our all-day operating, and that has created an extra all-day operating list for emergencies. We have a single list in the morning, 2 in the afternoon, and back to 1 in the evening. And that's had a significant impact. It's altered our timely care of the category 3 patients from 38 to 82% in the short trial period we've had it going. The other thing we could do is we could all campaign to have this 3 till 10 p.m. slot, because that's probably the time that fits best with the unwell general surgical patient. They've come in the night, they've had their CT scan, they've been assessed, they've been resuscitated. And having an organised slot there, I think, would make a significant difference. We have Surgeon of the Week now. What about having an on-call anaesthetist of the week, so that there's more of a teamwork, more of a commonality of how we sort these patients out? That might help. What about the team, though? Adam's hinted at this. Where's it gone? If you go back 20 years, we had a team of 4 who all worked together, at least 3 of whom were on the surgical pathway. I would suggest that now that's down to 2, and that furthermore, the experience that the middle grade members of the team have is substantially less than it was 20 years ago. And I think what these do is these represent a tipping point of a number of factors, hours, training, experience, manpower, that we've just gone over the edge of. And we're going to have to now think of different ways of doing things if we're going to make this better. The single-handed specialist registrar, who's going to help them do the laparotomy in the night? The GPFY2? I think that's for the birds these days. It's not only experience, it's number of pairs of hands, and it's no longer tenable, I think, to have a single-handed specialist reg doing a laparotomy in the middle of the night, primarily because of the risk associated with it. How are we doing in that? There's been a laparotomy network audit of over the last year. Many of you will have submitted patients to that, 100 hospitals, 1,800 patients. Here you see how we've done over the last year, that over 75% consultant surgeon involvement in daylight. It falls off at night when presumably the patients are sicker, and we're marginally ahead of the anaesthetist, but room for improvement in our hospital, as I guess in yours. These are obviously national data. How do we work that out? Well, risk prediction, I think, is another thing we can all do. We all estimate risk poorly, and that comes in both in who should be doing it, how urgently you should be doing it, where they should be going afterwards. And this would be a useful part of the checklist before surgery. There's a number of ways you can work out a 10% cutoff for consultant input. Use the P-POSSUM score that's on the web. ASA3 will do it. Laparotomy as an emergency, they're all over 10%, apart from a very simple femoral hernia, which comes in about 9.8. These other factors you see there, then if you are over 10%, consultant involvement over 5, but consultant presence over 10 would be the standard we would advocate. At the end of the operation, you should consider where the patient goes for critical care, but the next speaker is going to talk about that. You're going to say, how are we going to do all this? Here we see the manpower issues that, again, Adam has hinted at. These are all things we do on our weekend on call when the consultant's the only person there for 72 hours. Is it sustainable? If it is now, will it be when you're 67 and a half? That's open to some debate. How can we address that? Well, that's going to take significant and ongoing effort. Job planning has to be realistic. We can't tell you how your job plan should go, but the hours should add up. And if there are problems with that, if there are genuine problems, ASGBI is certainly interested in that. Emergency surgery is underpaid for the complexity, risk and stress. What we do have more control over is the team size and redesign. It's half our workload. Why then do we only have 1 reg out of 12 doing emergencies at any one time and 11 doing the electives? Defining the right length of duty period for your number of patients and complexity isn't easy. Again, as Adam said, they've obviously fiddled with theirs a number of times. And you've got to balance continuity of care with individual survivability, i.e. yours. At the moment, hospitals refuse to shut the doors, and we think that should change. We've had a number of circumstances in Salford where resus has been full, recovery's been full, consultant anaesthetist says we have no room, still the managers refuse to shut the doors. I think that's wrong, and I think under individual circumstances, hospitals should be able to triage and transfer. I think everybody should be able to revise their input to the on-call system at 55, and the ASGBI document states that. Perhaps the most important comment on this slide, though, is this last one, in that it's no longer possible to see your emergency work as an add-on to your real work. It's half the practice, it's most of the risk, it has to be properly resourced by us, and it has to be properly valued by us. What about training for the future? We've heard a bit about this. Has the focus been too much on subspecialty at the moment? Juniors tend to see it the same way seniors do, that emergencies are something that gets in the way of the real work. And some of the answers are here. I think there needs to be much more time and focus on emergency surgery training. 100 laparotomies is a minimum, I think, and people should train in general skills before they do the subspecialist ones. And thinking about that, that might mean a bit of a change around. Some of the things we could do, we could have fill-in short attachments near the end of training, things you've kind of missed out on or skated over. Should there be fellowships in EGS? And should all new consultants have a mentor in EGS for the first 2 or 3 years? What about reconfiguring, the thorny question? And I guess the big question is here, are we going to do it, or is somebody going to do it for us? And there are numerous angles here, and if you come to the hot topic tomorrow evening, you'll hear the upper-lower GI split in more discussion, I think, and also whether you should have generalism versus subspecialism. What I think we have seen is that subspecialism has kind of headed off in its own direction and has left the rump in the middle, which includes EGS, to almost in a way fend for itself as something of an afterthought. I think people looking in at how we cope with emergency surgery and surgery in total think we ought to sort all that out, and certainly some of the issues to do with training are going to be hampered if the ongoing debates and view divergence we have on how subspecialization works aren't sorted out reasonably soon. We'll be reconfigured, and that might happen in a way that won't help. How else can you sort the service out? I'm not going to talk about upper and lower at the moment for obvious reasons. Is merging hospitals the answer? Again, from the survey, we found that the average number of people coming in on the take was usually 10 to 15, but that relatively few hospitals felt they'd be able to cope with double that. So if you did just merge hospitals, as sometimes the politicians advocate, you might just find you have to have double the number of people on. So why not keep both hospitals open and avoid having to move elderly people in the middle of the night for assessment when they might not need it? So some services clearly demand centralization, others are clearly more effective nearer the patient's homes. Another thing you could do is to separate patients by risk. You could have low-risk hospitals with relatively lower resources and higher-risk hospitals who deal with the high-risk emergencies, complications out of hours, and some of the higher-risk emergencies also. What about the emergency general surgeon? Lots of advantages. A fair number of individuals have already been appointed, many very enthusiastic, but some of the issues are not sorted out, and again, that is certainly worthwhile. What's their scope of practice? It's not defined. They need a broad competence. Does the training program match that? I would suggest not always. Is it future-proof? How are they going to maintain elective laparotomy skills? What elective laparotomy operations are there that a generalist is allowed to do in inverted commas? Incisional hernia, colon cancer resection. Colon cancer specialists would say no. Evidence for that, not sure for colon, better for rectum. Must be an equal partner. Some of the trials of this where have seemed to fall down because there's a lack of resource and a lack of buy-in from the surgeons who are no longer doing emergency surgery. So I certainly think that everyone should continue doing emergency surgery and, if you like, share the misery till the end of their career, although the time of day they should be doing it should change as career progresses. And the other option that comes in with that is career progression with age. Early career, lots of emergency surgery maybe while you learn your subspecialty practice. Mid-career, a bit of EGS and a heavy specialist load. And then in later career, perhaps you should be doing daytime EGS and more general surgery. That would combine experience with energy of youth. It'd let you use both general skills while you learn your specialist ones, and hopefully it would let us expand the service, which we obviously need. What other changes as we get to the end? We need the beds in one place. Critical care we're going to talk about in a moment. Interventional radiology is appalling and needs to be networked. Team support, we've heard about specialist nurses. And what about hot clinics? We estimate that we could certainly save 1 in 6 of our emergency surgery admissions from coming into hospital if we had hot clinics with reserved imaging slots. Some units have scheduled theatre for abscesses, protocolized gallbladder management. That could all help. The funding for that, the tariff, I think, is also better. What that takes is local leadership, and we're not great at that, and that could be helped. Which option's the one for you then? Well, almost every hospital's different, and there are many angles, and that's going to depend on some of the characteristics you see there. But it also depends, I think, fundamentally on what our aims are. Is it to survive our duty period, or is it to help develop an excellent service? So in conclusion, Mr. Chairman, ladies and gentlemen, the media attention has given us a great opportunity to change that. People are listening, and if we've got cogent plans to put forward, some funding will be found, I think. The documents I've shown you are there to help you lay out and make your case. The key points are shown there. But I think the last two are critical. Ownership, we need to own this because change is going to happen. Otherwise, we'll have changes imposed on us. And emergencies, Mr. Chairman, are not an add-on to real work. Thanks very much.